our sponsor, and UAE University for providing and accrediting to CME for this webinar. I'd like also to thank our two distinguished speakers, Professor Ahmed Bahammam and Fatma Al-Ahmed, who will be giving their talks in a few minutes. So if everyone is fine, I would like to start by giving you some information about the webinar and how are you going to communicate with us or ask questions. So you're all muted for this webinar. So if you have a question, please type in the chat box. At the end of every talk, we will give a few minutes for asking and answering questions. Also, at the end of the webinar, there will be sometimes to ask question and answer your question as well. For CME accreditation, at the end of the webinar, you will receive an email with a link to evaluation. Please fill in the evaluation and you will get automatically the CME certificate via email. Excellent. So maybe I could start now and let me introduce myself. My name is Dr. Mohammed Al-Huqani. I'm Associate Professor at College of Medicine, UAE University. I'm also a consultant, respiratory and sleep medicine at the Sleep Disorder Specialized Clinic. I'll be talking about obstructive sleep apnea and remote care. So before we talk about remote care, let's talk a little bit about obstructive sleep apnea. So many of you know that obstructive sleep apnea is characterized by either partial or complete obstruction of airway. And we're talking about the area of the hypopharynx. And this is a recurrent obstruction that occurs overnight. We then investigate patients and we calculate it as number of apnea, hypopnea per hour, and we call it apnea-hypopnea index. Now, how common is obstructive sleep apnea? It's all depending on what is your criteria for diagnosis of obstructive sleep apnea. So it could range from 4% to up to 30%, depending on what's the criteria of the cutoff of the AHI. Like Wisconsin, for example, they use AHI more than 5 with Epworth Sleepiness Score of more than 10. We call this obstructive sleep apnea syndrome, which means patients with obstructive sleep apnea and are symptomatic. Now, why do we care about obstructive sleep apnea? We care about it because it comes with the consequences. It is unfortunately leading to many health consequences, such as cardiovascular morbidity and mortality, pulmonary hypertension, systemic hypertension, excessive daytime sleepiness, which could lead also to core collagen. And this is one of the studies that showed the mortality and morbidity related to obstructive sleep apnea in patients with cardiovascular disease. And basically, this is a Wisconsin cohort study where they followed patients with obstructive sleep apnea for 18 years. At the end of the study, they found that patients with severe obstructive sleep apnea has more than 3 times higher risk of mortality related to cardiovascular disease. Now, patients who have symptoms of obstructive sleep apnea used to be sent to a sleep center and get the gold standard polysomnography, where they will have, we call this the sleep study. Now, there are 4 types, and I believe Professor Ahmed Bahammam will talk about them. But this is a gold standard where patients go to the sleep lab and get hooked with EEG to check the stages of sleep, EMG, airflow, oxygen saturation, leg movement, snoring, video, and sometimes transcutaneous CO2. Again, this is a gold standard until we had the COVID-19 outbreak. This pandemic, unfortunately, has changed the way we take care of our patient and manage obstructive sleep apnea. And this, now, at least in UAE, the worst part was during May the middle of May, where we had almost 1,000 cases per day. The peak in in Saudi Arabia was toward, again, middle of June, and you can see it. The good news, it's going down in most of our GCC. Actually, I'm not happy about the number for the last 2 days. It's worrisome, and that's why we see many messages coming from Health Authority and Ministry of Health asking people to be careful, stay at home, and apply all the social distancing. Now, what do we have as a guideline when it comes to COVID-19 and sleep medicine? We're lucky that the American Association of Sleep Medicine has published the COVID-19 guideline, which help all of us to go through the strategies of managing sleep and sleep center during the pandemic. Let me do this. I'm just organizing my screen here. Okay, so basically the goal of this guideline was to support efforts to gradually and safely reintroduce healthcare services, also implement the best practice for infection prevention and control, also to minimize patient, staff, and provider exposure to the virus, maintain access to care and continuity of care, and to promote public health safety. Now, part of this guideline is screening. So a very important pre-screening to appointment. Well, if you can do the test, that would be good, but you could use phone calls, patient portal, or online self-assessment, asking patients about symptoms of COVID-19 or whether they are in contact with anyone with COVID-19 recently or recent travel. Also screening at a time of appointment. So even if they were fine during the phone call or self-assessment tool, make sure that you check their temperature when they come, and also go through the same checklist of symptoms. If anyone is having any symptoms, please reschedule their appointment until their test is negative. And very important that we should also screen our staff. Now, we should not forget the infection control, and one of the recommendations is that we should use telemedicine where available and when appropriate. And we all spend the remaining time of this presentation talking about remote monitoring, because that's for sure will reduce the time of patient in the clinic and hopefully reduce the chance of any infection. We should also review with the staff all procedures for infection control, and not to forget the personal protective equipment. Now, one of the important things is to have the online forms. And this is what we used in our clinic. Basically, patients before they come, they will have a link to their email or WhatsApp. They will go through some online COVID-19 checklist, asking them again of symptoms of COVID-19 or whether they had a close contact with someone with COVID-19 or a recent travel. We also try to minimize their time in the clinic. Like everyone coming to my clinic, they will fill in the Epworth Sleepiness Scale, Berlin questionnaire, Stop Bank questionnaire. What we're doing now, we're sending all these questionnaires online to the patients. So we try to register them online and also get all the questionnaires online. Now, I'd like to encourage you to visit our website, uaesleep.com. We have most of the questionnaires there. We're happy if you would like to use it from your side. Now, questionnaires that was very helpful, which minimized patients' time when it comes to registration and also waiting area, but very important to ensure distancing of 2 meters in both the waiting area and getting their temperature. Make sure that you have hand sanitizer across the waiting area and signs for mask, and no one should come in without mask. Also, your staff should always wear the N95 and the face shield. Communication is very important. It's really hard for many patients to come in to their doctors during the pandemic for many reasons. Many patients are scared to go to any healthcare centers. They're scared of getting infection. And sometimes during the lockdown, it's really hard for them to transport to centers and especially get treatment. And therefore, we should communicate with our patients. We should not forget them. We could use different modes of communication besides telephone, the online form, the WhatsApp, if possible. And this is one of our forms for the CPAP follow-up, where we ask the patients to go through some of the questionnaires. And I'll give you an example. This patient, for example, he wrote here that he will never sleep well with a mask. It seems that he had a problem. So immediately, we asked him to send us a photo of his mask. And it seems that his mask was very old. There's wear and tears. He purchased it in 2015, which is more than 5 years ago. Again, patients did not know that they need to change the mask almost every 6 months. And sometimes they lost follow-up, they may be out of the city. So again, communication is very important. And what we've done is basically we ship him a new mask, and that was all done without patient coming all the way to the clinic. He was actually in Dubai, we're in LA, but we managed to handle his issue. Now, remote care is a must now. We were talking about remote care for many years, believe me. We talk about remote care, and we talk about also remote teaching for students. And no one was able to, I would say, convince the community that this is important until we had the COVID-19 pandemic. And immediately, everyone switched to remote care, teaching, webinar. Who thought, like a few months ago, let's say in January, that webinars will be very popular? Again, these are things that we learned from the pandemic, that yes, this is not a choice, it's a must now. Patients cannot come in, students cannot come to school sometimes and cannot go to university, and therefore we should utilize the technology which are available for the benefit of the patients. So it started a long time ago. We used to bring patients, bring their device, hook it with a USB cable, and download the data. A long time ago, the data was very limited. All what we used to get there was the usage time of the CPAP. Later on, most of the CPAP provider, they developed a memory card, an SD card, that would have not only the usage data, but also the respiratory events like obstructive sleep apnea, central sleep apnea, hypopnea, and air leakage. And that was very helpful. And until now, so what I'm doing now is I'm asking my patients to get the memory card, download the folder there, zip it, and send it to us via email. And once we receive it, because it's a large file, we unzip it, put it back in a memory card and read it through the software. And by this, we can help our patient again, sometimes giving them advice, sometimes knowing that whether they have air leakage, or we can change a mask, or if they're still having some residual obstructive sleep apnea, we can increase the pressure accordingly. Now, lately, many of the CPAP vendors has introduced the wireless connectivity module. There are two types of module, either Wi-Fi or a SIM card integrated, which is even easier. And this SIM card will send the data to a central server. A physician can then download the data into his portal and monitor the patient. And we'll talk about this. Now, chronic respiratory disease is a very, I would say, major issue in many countries. Let's give you an example. In USA, there are 24 million patients with chronic obstructive pulmonary disease. 18 million out of them are patients with obstructive sleep apnea living on either CPAP or BiPAP devices. and we cannot afford to lose follow-up this large number of patients. Now, any patients who are on non-invasive ventilation, CPAP or BiPAP need to be followed up as per the American Thoracic Society CPAP adherence guidelines, where we need to monitor and ensure that they're using the device for not less than 4 hours per night, 70% of the night. We also need to ensure that they don't have residual obstructive sleep apnea and their apnea-hypopnea index hopefully below 5. We also need to ensure that there is no significant air leakage. And this is part of, I would say, the care of patients with obstructive sleep apnea. Now, that's what we used to do, despite all this, patients were having issues with compliance with CPAP therapy. The many studies that were done long time ago looking at different modality to improve the CPAP compliance. For example, having more of a group therapy or getting a telephone conversation with a sleep specialist or with a respiratory therapist. Many of them showed some improvement. Lately, and after telemedicine has introduced, many studies were done to test whether telemonitoring would improve the CPAP compliance. And these are one of the meta-analysis that was published actually this year and showed that telemedicine actually does improve the CPAP compliance for patients with obstructive sleep apnea. Now, the second question that everyone asks, well, does the telemedicine is a cost-effective or are we increasing the cost? The answer actually came that telemedicine-based strategy had lowered the total cost due to saving on transportation, that's for sure, and less of lost productivity. So many of our patients, unfortunately, living 1 hour or 2 hours drive away from us, and telemedicine save their time and save our time, actually, having them coming, and also reduce the risk of infection. So the goal, basically, if I'd like to have a good system, a telemedicine system, I'm looking for to reduce not only the cost, but to lower the risk of infection and improve the compliance. And we're looking for a solution that would continue to evolve and focus on providing care outside the hospital wall to achieve better outcome while keeping costs under control. Now, this requires new processes and system design to connect home care provider, physician, and payer with patient across the entire care continuum. So what we're looking for is an integrated and connected Empower system utilizing technology, resources, people, and information to manage sleep and respiratory patients. Starting from the medical equipment provider, to the therapist, to the physician, and to patient home. Now, we're hoping that whatever system we're going to adopt will be integrated with our electronic medical record and billing system. And we're looking for a system that would have a dashboard, easy to see all your patients who are doing well on a green bar, patients who are having issue, they would have a red flag. It could be an issue due to obstructive sleep apnea or issues due to leakage or not using the machine at all. Now, this comes with some challenges that I need to talk about, and I already spoke to many of the CPAP provider, and I said, where are you? And many of them, they're having issues utilizing this data in GCC country because there are some rules stating that patient data cannot be shared over the cloud. And therefore, they have to bring a huge investment and have server locally for almost every country. And this is something that we're talking about and trying to help and maybe minimizing the risk of sharing that data in the cloud and having our own server here in GCC country. Also, the other challenges are many of us are using different systems where the sleep equipment, sleep monitoring are totally different system than the sleep therapy and a totally different system than the electronic medical record, and all this need to be integrated. Now, where we are so far, there are three major CPAP vendors. ResMed has introduced ResMed Air Solution, Fisher & Paykel has introduced Info SmartWeb, and Philips Respironics has introduced Care Orchestrator. Now, I tried the Care Orchestrator from Philips Respironics, and I'd like to present a few cases here that we can discuss together. So the first case is Mr. Z. Actually, I received a phone call from his son, and it was middle of May, where almost no one is happy to go to any hospital or sleep in any sleep lab. And I was told that he was a 77-year-old, BMI 39, was not sleeping well. Actually, sorry, he was sleepy all the time. He's not sleeping well. He was sleeping all the time. His son read about obstructive sleep apnea, and he said, oh, this could be obstructive sleep apnea. The patient is ex-smoker. He has a 50-back-year smoking history. He's on home oxygen at 2 liter, and again, could not attend the clinic due to pandemic. So we've done the tele consultation online, and then we said, okay, you know what? It's very challenging to bring him to a sleep lab during a pandemic. Maybe we should move and do a home sleep study at his home. And by this, we minimize the risk for the patients and also for our staff. So a home sleep study type 3 was done for him that showed severe obstructive sleep apnea with apnea-hypopnea index of 62. The patient spent almost 90% of the time sitting below 90%. So he was not only having obstructive sleep apnea, but a significant hypoventilation. And you can see here, this is his oxygen saturation. This is his hypnogram, and he has a lot of hypopnea through the whole night. Now, let me ask you a question, and you could actually participate in this poll. What's your next step? So you see this patient, you got the report, he's symptomatic. Would you start him on a CPAP or BiPAP titration? Like, would you bring him back to the sleep lab? Or would you start him on nocturnal oxygen titration? Or would you give him an auto CPAP with close monitoring? Or maybe AVAPS, automatic volume assured pressure support with oxygen saturation module. Let me start and launch the polling. Now, okay, excellent. Now on your screen, you can choose what do you think and what would you suggest for this patient. And again, he's someone, he's around 70-year-old with history of smoking. Study showed severe obstructive sleep apnea, as well as some signs of hypoventilation. He's sitting most of the time below 90. He's already on 2 liter oxygen. Excellent. So things are going on. I'll wait for another 5 seconds before we end the poll. So you can see it in front of your screen. Okay, very interesting. So far, this is interesting. So many of you think that maybe we should start him on auto CPAP with close monitoring. Okay, so 40% think auto CPAP. 34 think maybe we should bring him back to the sleep lab and do CPAP BiPAP titration. Okay. 15% think we should just do oxygen titration. Interesting. And 9% think that we should start him on AVAPs. Wow. Okay, I think we need to talk about your thoughts. Great. So let's start one by one. Now, bringing patients middle of May when we had a peak of COVID-19 was almost impossible. Patient is already fragile and he's at risk of infection, and we did not want to bring anyone for CPAP titration because the risk of infection from the CPAP itself, and that would, no one was happy to do this. So option one, CPAP BiPAP titration would be fine if it was not a pandemic. I will, yes, bring him for a titration. Option two, nocturnal oxygen titration, is not a treatment for someone with obstructive sleep apnea or obesity hyperventilation. Option three, auto CPAP with close monitoring. Now, auto CPAP would be fine if he was just a straightforward severe obstructive sleep apnea. The reason I did not want to start auto CPAP because he's ex-smoker, he's severe obese, and the sleep study showed clearly that he is having sign of hypoventilation. So auto CPAP I would not agree with. Actually, we moved to ST with automatic volume assured pressure support with SpO2 module. Okay. Let me close it. Now, let's move on. So we started home with a minimum IPAP of 12, maximum IPAP of 16, EPAP, exhale positive airway pressure of 8, tidal volume based on his ideal body weight, 6 cc per kg, and a backup rate of 10. Now, many people ask me, okay, why did you start him on a maximum IPAP of 16? You could do like 25 if you wish. The reason when we started this on the patient, he could not tolerate a higher IPAP pressure. The maximum he could tolerate at that time was 16. So we said, okay, you know what? We should not push him. Let's start with whatever patient can tolerate and then come back and see him in a week. Actually, we don't need to come back and see him in a week because his machine had attached Wi-Fi module where I can view it from home or from my clinic, and I can see his usage. And this is actually what I see from my laptop. This is his usage. Look at the mask fit. Clearly, he has some leakage. In terms of respiratory events, he had AHI of 4.1 below 5. I'm happy for someone for the first night. Tidal volume was going up and down. His oxygen saturation, which was really good. I like having, for patients with either COPD or obesity hyperventilation, I'd like them always to have the SpO2 module. And clearly, he did have some improvement comparing to his sleep study, but he was still having a very low oxygen saturation. Okay. I can see his heart rate as well, his breath rate, which was almost 16, and whether he was triggering his breath. So overall, for the first 3 nights, he used the machine for 5 hours per day average. There was some leakage. His AHI was below 5. His average breath rate, 17. Patient triggered most of the breath by himself. The tidal volume was 286, the minute ventilation 4.8, and the IPAP most of the time was at 16, which is the maximum that we set. Now, if you've seen the patient and now you're seeing his ventilator statistics, what would you do next? Let me put the poll. Okay, launch it. Okay. Would you increase the maximum IPAP? Currently, he's at 16. Or would you increase the EPAP? Or maybe the tidal volume or the breath rate? Huh. Okay, I'll give you 10 seconds. So again, the patient, despite having the AVAPs, we've seen that his oxygen saturation is still below 19. It did improve a little bit, but still below 19. And clearly, he did not reach his target tidal volume, which was supposed to be 400, and he reached almost 250. So what would you do? I know it's tricky. And that's why I see Very interesting to see your result. Okay, I'll give you another 3 seconds. Okay. Excellent. Now we should talk about it. Now let's start from the last one, increasing breath rate. Now the patient was triggering very nicely and his breath rate was around 16, so I would not increase his breath rate. Okay. Now your second one, increase tidal volume. Well, we already set up the machine to ideal tidal volume, which is 6 cc per ideal body weight. It was around 400, but the patient did not achieve the tidal volume. So increasing the tidal volume on this type of machines with an IPAP of 16, you would not reach your ideal tidal volume. So that would not be a solution. Increasing EBAB, I saw 28% here. No, I would not agree because his apnea, hypopnea index is below 5. So remember, we increased the EBAB to treat the obstructive events. And he does not have any more obstructive events. His issue now is hypoventilation. So what we need to increase is the IPAB, okay? And because IPAB was limited to 16, the machine could not deliver the ideal tidal volume. So yes, we need to increase the IPAB. Okay. Okay. Great. So one of the advantages of remote monitoring, you have like a My Task list and you can see patients who are doing well, like someone who's compliant, and patients who are at risk, for example, due to a large leak or maybe a high tidal volume. So very nice if you sit and got a dashboard and see alerts, for example, there's a high leak, you could call in the patient, what's going on, and then you learn from them what's going on with their mask, maybe tubes, okay? Also, there's a tidal volume alert, especially for patients who are either COPD or having obesity hypoventilation. And again, if you see a tidal volume alert in patients with AVAPs, think that maybe they need more IPAP, maximum IPAP, okay? So, I think it's almost 30 minutes. I'll try to end up my presentation. So the teaching point here that during pandemic, it's yes, challenging, but we need to move into remote care. We need to not forget our patients, call them, communicate with your patients, especially those who are on ventilator, CPAP or BiPAP. Try to find innovative way to get their data, help them while they're at home. With all the technology now that we have, that we could share with the patients via WhatsApp, online forms, telemedicine, but we should move and start approaching and getting our patients the best care that we can. Thank you very much. And if you have any questions, I think we'll give it 2 minutes for questions. Thank you.
Thank you, Dr. Al-Rukhani. And now we can proceed with the second speaker.
Excellent. Okay, so now it gives me great pleasure to introduce Professor Ahmed Bahammam, who's a consultant of pulmonary medicine. He's also executive director of academic affairs at King Saud University. Now, Professor Ahmed Bahammam, we call him the father of sleep medicine in Middle East. He's, mashallah, very actively publishing. He established the Gulf Sleep Group. We always learn from him. And he will talk to us tonight for the next 30 minutes on leeway during COVID-19 pandemic. We'd like to welcome Professor Ahmed.
Assalamu alaikum, good evening. Thank you, Dr. Muhammad, for the invitation and for the introduction. Today we'll talk, or this evening we'll talk about the home sleep apnea testing. And its application during COVID-19 pandemic. So I'll just try to time myself. Okay. In this lecture, we'll aim to, by the end of it, that we can understand the need of home sleep apnea testing. If we see HSAT means home sleep apnea testing, which is the name used now by the American Academy of Sleep Medicine. Also, the utility of home sleep apnea testing during COVID-19, the identification of patients in whom home sleep apnea testing is likely to be successful, the assertion of staff and patient safety during home sleep apnea testing, the importance of cleaning devices after the study, and the utility of unattended auto CPAP titration to complete the work by diagnosis and treatment. I'll get the information from 2 recent papers that we published. You can take a screenshot of these and you may find them. They are available. Springer makes all research related to COVID-19 freely available online. You can get it from the Springer website. Reopening sleep medicine services and the conundrum of an ongoing COVID-19 pandemic. And the other one, management of aerosol during non-invasive ventilation of patients with sleep disorder breathing, important messages during the COVID-19 pandemic. Just to get some background, before COVID-19 pandemic, this is from a recent paper published from the European experience, what they have there. In-lab titration was representing 90% and ambulatory titration 55%. That dropped to 17.5 and 22.5 in ambulatory titration. So COVID-19 impacted, as Dr. Mohammed mentioned, the treatment of patients with obstructive sleep apnea significantly, whether you will do it in lab or at home. The outline of our talk is introduction, types of home sleep apnea testing, indications, contraindications, and limitation of home sleep apnea testing. Home sleep apnea testing during COVID-19 pandemic. I have here a few things, I don't know how to remove it. Black screens appearing here. When we talk about home sleep apnea testing, it refers to the diagnostic evaluation of sleep apnea outside the conventional sleep laboratories, and typically consists of a small recording device with sensors, belts, and related accessories. And they are worn by the patient at home, so there is no need for anyone to go and set it for them. This is the ideal situation, that patient should be able to wear these devices at home with no assistance. The advantage is that it will reduce the need for expensive time and labor-consuming laboratory testing. Also, the long waiting list, so you have quicker diagnosis and treatment initiation. And it's more convenient for patients as well. Home sleep apnea testing had been classified long time ago by the American Sleep Disorder Association in '94, which is now called the American Academy of Sleep Medicine. New classification have been published after, but people still refer to the old classification because it's more practical. So they have type 1, which is the in-lab diagnostic, which is usually cardio or neurocardiopulmonary monitoring, where we have EEG, EMG, respiratory monitoring, including pulse oximeter, and ECG and EMG. So this is the classical one, we know it. Type 2, it's called comprehensive unattended. You have the full monitoring, but it is unattended, but it needs a sleep technician to do the hookup process, then leaves, then come in the morning to unhook the patient. So this type is used mainly in research. It's not practical to use for home sleep apnea testing because it needs a technician and it's time consuming. Type 3, which is the main type when we talk about home sleep apnea testing, it's cardiopulmonary monitoring, usually 4 or more channels, can be more than that. And we'll spend some time talking about that. We have airflow, belt efforts, oximetry, ECG, and it is unattended. And then type 4, which is called single or dual home sleep apnea testing, and has only pulse oximetry or pulse oximetry plus flow. And the evidence for this type of sleep study is not strong enough to recommend it for routine use at home. So when we'll talk about type 3. So type 3 utilizes at least 4 channels, 1 or 2 channels of respiratory movement, nasal flow, oxygen saturation. You can add more. I'll show you some examples. It does not record the signals needed to determine sleep stages or sleep disruption, like arousal. So you don't know what stage and if the patient has arousal or not. And we'll talk in the coming slides about the impact of that. There is no EEG, as we discussed, and a technologist is not needed to be there. The patient can do even the connection themselves without the need for the technologist. This is an example of an old model of type 3 sleep study, where you see here the respiratory effort sensor belt, the pulse oximeter, and the nasal flow. This is one of the old models that we used around probably 2001, 2002, and there are better models now. This is another more recent model where we have flow, snoring sensor, thoracic belt, as you can see, oxygen saturation, heart rate, body position, and rhythmography. Okay, this is an example. Sorry, I'm just getting busy with my cell phone to see the time. This is an example of home recording where you see here the saturation. There is, you see some desaturation here. This is the heart rate, the flow, effort, and this is a marker. The patient will mark if he goes to the bathroom, when he goes to bed. So when you score the study, you know that at this time the patient marked here he or she went to the bathroom, so that part is not included in the recording. And this is the sleep position. Type 3 monitoring has advantages and disadvantages. The advantages include easy to set. So it is easily done. Patient can do the hookup by him or herself at home. Lower cost for the patients. It's very portable and reduced number of signals, so it's easy to connect the wire, and it's easier to score and faster to score than scoring a type 1 sleep study. Okay, the disadvantages: reduced number of signals, because when you have less signals, then you have less information, and this will affect the results that you get at the end. We'll talk about it in the coming slides. You have to check about reimbursement by insurance companies. In the Gulf countries now, I think insurance companies, they start to reimburse for home sleep apnea testing. In the US, they have done. So if you are in a different country, check if they have reimbursement for that or not. Signal loss at home, there is no one to fix it. But we have studied that before. For the sake of time, I deleted those slides. But the rate of signal loss actually is not that high. It's around 3%. So signal loss, if you teach the patient how to do it, is not that high. And it still needs manual scoring. This is the recommendation of the American Academy of Sleep Medicine. What are the problems or limitations? We'll discuss them in more details. You cannot detect arousals. So when you cannot detect arousals, this means that you will not score hypopneas that are followed by arousals. Because you know that when you score hypopneas in the recommended scoring criteria, it's followed by desaturation or arousal. And some patients, they have good lung reserve, high FRC, so they don't desaturate quickly, but they have frequent arousals with hypopneas. And that's pathological, that's not normal. So you may miss all of those hypopneas that are followed by arousals because you are not scoring arousal. I'll show you an example of one of our studies as well. After that, I don't know what's the problem. Okay. The apnea-hypopnea index then will be underestimated because you will underestimate the hypopnea index because you will not score hypopneas that are followed by arousals. Okay. That's why the American Academy of Sleep Medicine recommended something called respiratory event index. So if you score a home sleep apnea test, then don't use the apnea-hypopnea index, use this REI, respiratory event index, because this is the term that reflects that hypopneas were not properly scored. Also, some of the portable devices, they do not have position sensor, so you will not know if it is position-related sleep apnea or not. The new devices do have a position sensor. You cannot distinguish REM sleep from non-REM sleep. And we know now that there is an important phenotype of obstructive sleep apnea called REM predominant or REM only OSA, which has significant pathological impact on the cardiovascular and metabolic system of humans. So it is not like as before, they thought it's not pathological. These patients are less symptomatic, but they have apneas that are mainly occurring during REM sleep. So this could be a problem here, because if the patient, for example, has 10 or 15 minutes of REM sleep with apneas and hypopneas condensed in that period, when you divide it by the time embed, it will be diluted, and the REI or AHI at the end may be normal. So you may be deceived that this patient has normal, or say he doesn't, or she doesn't need treatment. I'll show you some examples of that. And most of the available devices now, you cannot initiate positive airway pressure while monitoring, like what you do in lab. New devices now, you can do that, but most of them, you cannot record sleep while you are doing the titration. Okay. The American Academy, I'm sorry, have a lot of black windows here. Don't know how they cover even the, yeah, okay. Okay. The American Academy of Sleep Medicine guidelines, 2017, they put some recommendations. They said that clinical tools, questionnaires, and prediction algorithms should be used to triage patients for indication and contraindication of home sleep apnea testing. So home sleep apnea testing is not good for every patient with sleep disorder breathing. We'll talk about that in some details. And also they recommended that if you want to get a home sleep apnea device, make sure that you get a technically adequate device, which is validated, get information about it, if people have to use it in publication. Is it a good device or not? And you do the study for patient with uncomplicated obstructive sleep apnea. So you do it in patient with moderate to high likelihood of obstructive sleep apnea who do not have comorbid condition like congestive heart failure, neurological disorders, chronic lung diseases like COPD, and this because home sleep apnea testing has not been validated for patients with other breathing related sleep disorders. It's only for obstructive sleep apnea, and we'll talk about that also in some more details. And if a single home sleep apnea testing is negative, then studies showed that repeating the studies or doing more studies at home is not useful. So it's better to go and do a lab study if that's feasible. This time it is more feasible because there is a recession in corona cases, so it's more feasible to do. Okay, so the one who should decide who should go for home sleep apnea testing is a physician. A technician cannot decide that. Physician has to assess the patient and decide that this is a patient with high likelihood of moderate to severe OSA, and there are no comorbid conditions that may confuse the pictures. Because home sleep apnea testing is not, as we said, for patients who may have hypoventilation, who may have heart failure and transtop breathing, who may have COPD. This device has not been validated for those group of patients. You may use it if you have to, but it's not recommended officially yet. Okay, home sleep apnea testing for diagnosis of OSA should be done only, as we said, in medically uncomplicated adult patients with high pretest probability of moderate to severe OSA. And make sure that these patients, they don't have significant cardiopulmonary disease, they don't have neuromuscular conditions, no history of stroke or chronic opioid use, because these patients are more likely to have central sleep apnea. Those who may have central sleep disorders, different type of it, it's not good for them. Those with parasomnias, narcolepsy, other sleep disorders like insomnia, this home sleep apnea testing is not for them. That's why they used to call them portable sleep study, but now they use home sleep apnea testing to indicate that this study is for sleep apnea, it's not for other sleep disorders. It shouldn't be used as a screening tool or a screening method. This is, if you suspect, you go. It's a diagnostic way, it's not a screening. Screening, you can use questionnaire. Also, the American Academy does not recommend the use of home sleep apnea testing for diagnosis of sleep apnea in patients younger than 18 at this time. There are some off-label anecdotes of effective use of these devices in children, but still is not recommended officially. So what are the conditions for success? Proper selection of the patient, high likelihood of moderate to severe OSA, appropriate portable device application, interpretation by a qualified person, because it needs also interpretation and manual scoring, and I'll have one slide on that. You should have accessibility to in-lab BST if needed, because these devices are good to rule in, not to rule out OSA. If there is high clinical likelihood of moderate to severe OSA and the home sleep apnea testing is negative, then you do not rule out sleep apnea. They should go for in-lab sleep study. Systematic follow-up after that by a qualified physician. Okay, this is the data about what I have it here. For type 3, it is 2 to 18% in different reports. Type 4, 7 to 10%. Type 2 is not used, but we used in research, and we have a signal failure rate of 3%. So the failure rate is not that high. It's acceptable. It's acceptable. Now, the American Academy also, they have some recommendation, because you don't have EEG. As you don't have EEG, you don't know what's the total sleep time. So when we calculate the apnea-hypopnea index, usually we divide the number of apneas and hypopneas by total sleep time. As we cannot measure total sleep time, what we do, we divided the total number of apneas and hypopneas by time in bed. So if a patient goes to bed at 10 p.m. and gets up 8 in the morning, so he spent like 10 hours in bed. Maybe out of these 10 hours, he slept only for 5 hours. So if you divide the number of apneas and hypopneas, say 60 by 10, it will give you 6. But if you divide 60 by 5, it will give you more. So dividing them by time in bed will dilute the number of apneas and hypopneas. And this may result in diagnosing patients as normal when they have moderate to severe OSA. That's why there is some suggestion for using actigraphy. The American Academy suggests that in the statement in 2018, that clinicians use actigraphy should be integrated, built in with the portable device. So there will be synchrony in time. You can have the exact time recording with the home sleep apnea test devices to estimate total sleep time during the recording, in the absence of alternative objective measures of total sleep time in adult patients. And this is conditional. When we say conditional, means the evidence is not strong, but based on the available data and consensus of experts, this is our recommendation. So this is an example here of the actigraphy. Patient is asleep. Here you can get exactly the total sleep time, and then you can divide the number of respiratory events by the actual total sleep time, not by the time in bed. This is a paper we did earlier where we compared different scoring criteria and the impact of that on the apnea-hypopnea index. If you look to the last one here, which is severe apnea, so severe OSA, HI 30 or more. This is the 2012, where we use both desaturation or arousal to score hypopnea. Met the criteria for hypopnea, followed by desaturation or arousal. Look at this, compared to this gray color, where you depend only on saturation. So you see the difference? So when you don't have scoring of arousal, you will underestimate the number of hypopneas. And some patients, especially women and young adults, they get more of hypopneas rather than obstructive apnea, complete apnea. So when they get obstructive hypopneas and you don't score them by arousal, you may underestimate the severity of OSA. You remember I talked about the REM OSA. The REM OSA, as you don't have EEG, you cannot score REM. But when you see periodic desaturation like this, you see this is REM, this is a histogram, this is a hypnogram in the top. When you see periodic desaturation, this periodic desaturation suggests, especially if it comes at almost intervals that seems to be regular and clustered together, it suggests that this is probably REM related also. It could be also position related, but usually position related do not have the significant desaturation and high apneas and normal in between. So if you see this pattern of desaturation and cluster of obstructive apneas and hypopnea, this is suggestive of REM-related OSA. So you have to explore that, but you have to bring them to the lab, because if they are symptomatic, you need to treat them. Because as we said, the current evidence now suggests that this may not be benign, it needs to be treated. This is another example, just by pulse oximeter. You see this periodic desaturation. This periodic desaturation for the whole night, suggestive of, especially when you get it like 4 or 6, because usually we have 4 to 6 cycles of REM. You get 4 to 6 cycles of this coming at not exactly regular, but semi-regular period. This is suggestive of REM-related OSA. Okay, so as we said in the earlier slides, a single night of pulmonary testing should be sufficient with a technically adequate test in the proper patient population. This is American Academy of Sleep Medicine recommendation. Limited data to support the superiority of multiple nights versus one night. Multiple nights may increase cost with no benefit. That's why if a single night fails, the recommendation is to go to in-lab sleep apnea testing. And what's the time which is adequate for? The accepted now is 4 hours or more, 4 hours of recording time with adequate flow and oximetry data during the habitual sleep period. Again, the evidence is not showing this a conditional recommendation. Okay. And what about automated scoring? Many people, they do the home sleep testing, then click enter, and the machine will score it automatically. Still, the recommendation is to go for manual scoring, because the agreement between automated and manual scoring of home sleep recording varies based on the device and algorithm used. So for type 3, HI correlation varies between 0.6 to 0.98. 0.98 is good, but 0.6 may not be good. And the range of difference 5 to 8 events per hour. We have worked with that, but because for the sake of time, I am not presenting our work that we have published before. So what I suggest that it's better to go with manual recording, especially if you are critical about collecting data, critical about like using them for research. It's better to do it manual. If it is clear-cut obstructive sleep apnea with desaturation and you don't care about that, just you want to treat the patient, and the device you use have been validated for like reasonable results for automatic scoring, then probably you can go for the automatic scoring. And the American Academy still recommend raw data must be reviewed due to limitations of current automatic scoring algorithm that restrict their diagnostic accuracy. And then just we'll move quickly to the COVID-19 virtual clinic. Dr. Al-Fawqani covered that. In the setting of a pandemic, home sleep testing can really provide some mitigation, online assessment, virtual clinic. It's good so the physician can assess the patient and then decide if the sleep apnea testing at home will be good for them or not based on the clinical assessment, and decide whether the patient can take it at home. There is no, it's recommended that there should be no physical contact between patient and the staff, and this is the aim of the home sleep apnea testing, because if the technician will go to them at home to do the hookup and connection, then the risk of spreading the infection is there. So what I recommend, and others recommend, the ideal situation is, this is very simple, patient can do it at home. Equipment can be delivered through courier, so they will receive it at home with the educational brochure, or they can have an education online video. They check how to do the connections, and before you go to bed, just you connect it. Then in the morning, just ship it back to the center, or someone just come and collect it from in front of the house, just out at the door, just pick up the equipment and go to score the data. Instruction to use and safe handling can be passed through brochures and telemedicine portals. Disposable equipment and its components are preferred, so like nasal cannula should be disposable. If you have also pulse oximeter, which is disposable, that will be better. So tell the patient, don't bring it, just throw it after that. And centers do not need like elaborate preparation, because everything can be done at home. The advantage that you don't have to screen patient and point of contact for corona, because they will have it at home, they will have the equipment at home, they will do the study at home, so we don't need to do the screening. For us in our hospitals, before we bring them to the lab, we do for them SARS-CoV swab, and it comes within 48 hours. If it is negative, then we take them to the lab, so you save that money. Patient is not exposed to the community or healthcare environment. Alhamdulillah, now lockdown is less, but if there is lockdown, usually quarantines also does not hinder the use because you can deliver to them at home and then just pick it from them at home. As we said, use single-use fully disposable devices or its components. The choice of the home sleep apnea testing model is to ensure a home delivery, something easy that you can deliver at home. Patient should be provided the instruction guidance to ensure proper setup and safe handling. And if reusable devices are used, the unit must be cleaned and sanitized according to the infection control guidelines and manufacturer instructions. Fatima will talk to you in her video about some of the methods how to do that, and also more description, as I said in our papers that I showed you initially. It is recommended that you keep the devices for 3 days between use. So if you have more than one home sleep apnea device, you can spare one, use one, and keep it for 3 days, because even if there is a virus, it will die by that time. Units should be delivered in sealed, stamped package. This is what I recommend. So people, the patient will know that this has been cleaned and sanitized when they receive it, because you don't want any patient to blame you at the end that you caused an outbreak of corona in their house. Individuals responsible for handling and cleaning reusable home sleep apnea testing device after use must wear appropriate PPE. I'm just almost finishing now. Okay, so now you diagnose the patient. Then what's next? Should I bring him to the lab to do the titration? No, you can do unattended titration. Unattended with auto CPAP. This has been approved, but home titration with other devices is not approved yet. So unattended auto CPAP titration, there is good evidence that it is very effective, as good as in-lab titration, but you have to bear in mind that these studies that we have here are done by experts in the field who don't know when it is done by GPs, will they have the same results or not. This is a summary of the studies that have assessed type 3. It's very effective with different number of patients. Most of the studies assess type 3 actually. As we said, you have to remember that, as we said, for sleep at home apnea testing, patient with comorbid condition is not good. Also, auto titration should not be used for patients with cardiopulmonary disorders, patients who do not snore, because one of the algorithms to detect obstructive events in the auto CPAP is snoring. Patients with central sleep apneas also, auto titration is not good for them. Apply all precautions for boosted airway pressure therapy to minimize the risk of aerosol infection. And this you can find in the paper that we have about the management of aerosol. The last slide here is just an algorithm to see that how to approach home sleep apnea testing. Then I'll stop here at 30 minutes exactly. So you have pre-test clinical assessment, patients having high risk of or high likelihood of moderate to severe OSA. Then the suspicion is high. We go for schedule patient for home sleep apnea testing. Then is this positive for OSA? If they have OSA, it is positive for that. Then the next question is positive airway pressure titration needed? You think that they need treatment with positive airway pressure? If yes, make sure that they don't have heart disease, chronic lung disease, neurological diseases, or they don't have like upper airway surgery before, because the detection of apneas, if they don't have snoring, may be less accurate. And then do for them the study and do for them the titration and prescribe CPAP. How many nights you should use auto CPAP? There is no agreement on that. Most of the studies use few days, like 3 to 4 days. I would say like using 2 to 3 nights is adequate. You keep the auto CPAP with the patient for 2 to 3 nights, then you take the device, download data as Dr. Al-Fawqani showed you, check what's the optimal pressure that they spend more than 90% of the time in that. Then you can prescribe them even conventional CPAP, because for us, we care about cost. The cost of one auto CPAP, we can buy 2 conventional CPAP. So we give our patient, about 90% of them, we give them conventional CPAP. So you can do the titration with auto CPAP, then you can prescribe the conventional CPAP after that. All studies have shown no difference in adherence between using conventional or auto CPAP. International, also our local data, in both patients with dense stage specific OSA and REM predominant OSA, there was no difference between auto and conventional CPAP. So you don't have to use auto CPAP after titration. You can see the data, you can prescribe conventional CPAP, then you follow them in the CPAP clinic after that. The key points here: home sleep apnea testing is a good alternative in patients with a high pretest probability of moderate to severe OSA, particularly during COVID-19. Home sleep apnea testing should not be routinely ordered in those with coexisting sleep disorders, morbid obesity, and severe cardiopulmonary disorders, because these cases are complicated. Interpretations of studies must be done by technologists, certified technologists, or qualified sleep medicine specialists. You cannot rely on auto scoring. A negative home sleep apnea test should prompt an LLAB PSG. All patients undergoing portable monitoring should receive a follow-up visit, because it's not enough just to leave them after that. They need regular follow-up. I'll stop here. These are the papers that I told you. I'm sorry that I have a lot of black windows coming in when I'm talking. They cause me some distraction. That's why I don't know whether you were hearing me or I lost signal while talking. I'll stop here. I'll stop sharing as well, so I can see what's going on around. And
excellent.
Back to Dr. Muhammad.
Well, thank you very much, Professor Ahmed Bahammam. Very interesting, and it seems we will do more home sleep study for the next year until we get, inshallah, the vaccine, and inshallah, we eradicate the COVID-19. Now, I suggest that we move to the third speaker. I know Fatima has prepared a very nice video as a short video. And after the third speaker, then we will take all the questions. I encourage all the participants to write their question in the chat area. We will read it in 6 minutes after Fatima talks. Now, it gives me a pleasure to introduce Fatima Al-Ahmed. She's a respiratory therapist and sleep technologist at King Saud University. She graduated from Toledo University in the United States of America. Fatima will talk about disinfection of sleep lab equipment. Please welcome Fatima Al-Ahmed.
Good evening, everyone. My name is Fatima Al-Ahmed, and I am a polysomnography technologist. In this video, we will talk about the disinfection of equipment after sleep study. I will divide the video into two parts. The first part, we will talk about the disinfection of sleep diagnostic system and its accessories, and the second part will be the disinfection of PAP device and its components. First, we will talk about base station, head box, brusher transducer, and patient cable. Clean the base station, head box, brusher transducer, and communication cable with a soft, damp cloth between use with patients. Make sure all parts are thoroughly dry before using. But be careful. Do not autoclave, gas, or brusher sterilize the diagnostic system, and do not soak or immerse the equipment in any liquid. We will talk about the sensors now, and we will start with the nasal cannula. Important, the cannula is a single use only. After one use, dispose the cannula. We should use disposable sensor as much as possible to prevent the spread of disease from one patient to another. Microphone and airflow sensor. Immerse the microphone and thermistor in Sidex and Omnicide solution for 30 minutes. But be careful, do not immerse the other side of the sensors in any solution, as it might damage the head box or the sensor itself. Effort belts. Wash the belts using warm water and household laundry detergent. Rinse them with water again and let them for air dry. There are some safe cleaning products that can be used without degrading the belts or shorten the useful life, such as Amphil Hospital Bulk Disinfectant Cleaner, Diacide, Ultra Disinfectant, and Cavicide. Now we will talk about the SpO2 sensor and oximetry. We have two kinds of SpO2 sensor. We have the disposable and reusable. For the disposable SpO2 sensor, it's for single patient use only, so dispose the sensor after the sleep study. For the reusable SpO2 sensors, clean the sensor with a soft wet cloth with a mild detergent or a 10% bleach and 90% water solution. Household bleach contains less than 10% of sodium hypochlorite, so you might need more of that amount with 90% of water. Body position sensor and snap electrodes such as ECG and leg EMG. Clean the sensor with a soft, wet cloth with 70 to 90% of isopropyl alcohol. Gold disc EEG electrodes. Soak in general disinfectant according to the manufacturer's directions after each use. Brush and rinse with warm water, and then you may disinfect them with sodium hypochlorite, Cidex OBA solution, or activated glutaraldehyde such as Cidex and Metricide. Now we will talk about the second part of the video, which is the disinfection of positive airway pressure devices. For positive airway pressure device, wipe the outside of the device with a cloth slightly dampened with water and mild detergent. Let the device dry completely before plugging in the power cord. Humidifier. It is recommended in this period to avoid using heated humidifier to prevent any droplet transmission. Heat and moisture exchanger HME can be used as a disposable humidification method. If HME is not available and the patient cannot handle PAP therapy without humidity, you may use the heated humidifier. For cleaning the humidifier, empty any remaining water. Wash the water chamber in the sink with warm, soapy water. Rinse well and drain out as much of the water as possible. Let the chamber for air dry before placing it back into the CPAP unit. Tubing. Disposable tubings are preferred to use at this time. Discard them after each use. If disposable tubing are not available, you may use reusable tubing. Gently wash the tubing and mask adapter in a solution of warm water and a liquid soap. Rinse thoroughly and let it for air dry. Do not clean the tubing and mask adapter with bleach, alcohol, solutions containing bleach or alcohol, or solutions containing conditioners or moisturizers, as it may impact the performance of the product. Air inlet filter cleaning and replacing. Clean the gray foam filter at least once every 2 weeks and replace it with a new one every 6 months. The white ultrafine filter is disposable and should be replaced after 30 nights of use or sooner if it appears dirty. Do not clean the ultrafine filter. To conclude, cleaning and disinfection of equipment is a link in the chain of safety and infection control. Disposable and single patient equipment are preferred, especially during COVID-19 pandemic. Always check the manufacturer's instructions, as they may differ from one company to another. At the end, stay safe and thank you for watching.
Excellent. Well, thank you very much, Fatima. And we'll spend the next 10 minutes, if you wish, answering your question. So I can read your question from the chat group. The first question that I have in front of me from Ammar Ashur, who said, patient with COVID and obstructive sleep apnea admitted with COVID pneumonia, can we keep them on their home CPAP device, and should any precaution be taken? Should we avoid browning them, and should we provide oxygenation plus CPAP/BiPAP if patient is desatting while on the CPAP? Maybe I'll ask Professor Ahmed to answer this question.
If there is a COVID-19 confirmed case, then if the patient doesn't need non-invasive ventilation, it's better to avoid it. Because with non-invasive ventilation, you increase the aerosol, which carries the virus. So you increase the risk of infection to the staff working with the patient. Even patients with obstructive sleep apnea, if they are admitted to the hospital with, even if they don't have COVID-19, but at this time of COVID-19, we say if they don't need CPAP or BiPAP, it's better to avoid it. However, if we have to use it because they have severe apnea, like obstructive hypoventilation, or if they have desaturation, there are some precautions. First of all, these patients they have to be put in a negative pressure room. You can't put them in a regular room with others because the aerosol will spread the virus to few meters around the patient. So everyone there will be exposed to the virus. I don't know if there is time, I can share one slide from our, to show this, or they stop the sharing again. Okay, so it's better to use in these patients, if they have acute respiratory failure, it's better to use the non-vented mask. I don't know if, yeah, okay, I can show you this. Okay. It's better to use the non-vented mask because the vented mask, if you see here, the vented mask, there is leak because it has holes. So these holes can carry the aerosol. So it's better to use a non-vented mask like this, a non-vented mask, to minimize the risk of aerosol. If you can use a ventilator with 2 tubes, it's better than 1 tube. So you can have one for inhalation, one for exhalation, and exhalation will go through a filter. So all viruses will be removed before the air goes into the room. If not, then probably you can apply a bacterial filter like this in between. But ideally, you should have not 1 limb, 2 limbs ventilator and non-vented mask and a negative pressure room. Okay.
Excellent. Well, thank you, Professor Ahmed. So to summarize for Dr. Ammar, better to use the hospital BiPAP that comes with non-vented mask. And if you can avoid humidifier and use HME, that would even be better. Sometimes you cannot avoid not giving them the BiPAP, especially if they're hypoventilating, because that would worsen their pneumonia. So, but you need to ensure, yes, with all what Professor Ahmed just said, the infection control, hopefully HME, non-vented mask, and a negative pressure room. Excellent. Now we have another question. Any rule for hypnotics in testing sleep apnea? Professor Ahmed, would you like to answer this question?
Yeah, this is a tough question. OSA now have been described to have phenotypes. And this is difficult for anyone just to detect that. And one of the phenotypes is called the high loop gain, where they have low threshold for arousal, high sensitivity to the upper airway, low threshold for arousal. So they have arousal, hyperventilation, then they may have some drop in CO2. And obstructive apnea, it's thought that it starts as central apnea. So there is central apnea and obstructive apnea. So this low threshold for arousal or high loop gain may precipitate recurrent obstructive events. So in this type of this phenotype, the idea about using hypnotics came. And then there are different hypnotics. Zolpidem, for example, have been shown even to increase sometimes the activity of the genoglossus compared to zobiclone and benzodiazepines. So this is a complicated topic. This is just a summary of the answer. I don't recommend using it. It's for the expert to decide if this patient may benefit from a hypnotic, if they have what we call the high loop gain phenotype, where they have low threshold for arousal. Otherwise, hypnotics may increase the risk of apneas, though a recent meta-analysis didn't show that. And for the non-benzo Z drugs like zolpidem and zobiclone, probably they are less likely to precipitate obstructive events. So I hope that just I put an outline of a difficult topic.
Well, thank you, Professor Ahmed. Maybe just for the question, if it is related to testing, if the question is related to testing in a sleep lab, what we used to do also, we advise the patient before coming to the sleep lab to wake up early morning and try to avoid any naps during the daytime, so that at least that when they comes to the sleep lab, they will be sleepy. And sometimes, yes, we do give non-benzodiazepine to help them if needed. Non-benzodiazepine, the many studies show that would not worsen the obstructive sleep apnea. Also, there are some reports showing that non-benzodiazepine for patients who are having difficulty sleeping may be prescribed for patients who are having, again, the combined insomnia and obstructive sleep apnea for the first few weeks to get to adapt to the obstructive sleep apnea. Okay, now let's see if we have any other question. Okay, I'll read this question. I'm a GB doctor, and I'm seeing a lot of patients in the last few months since the pandemic expanded that are experiencing sleep deficiency, okay, due to anxiety and job security issues. Please advise, what is the management approach as a GB? Do you recommend any specific medicine? Okay, well, Professor Ahmed, you can take this. I think this is by itself, maybe it should be a webinar with a psychiatrician, a sleep medicine into the insomnia, and maybe some cognitive behavior therapy, but I'll leave it to Professor Ahmed.
Yeah, again, this is a difficult question, and this is common now with any sort of crisis. People may have insomnia.
Yeah.
And as we know, for insomnia, the best treatment is the cognitive behavioral therapy. But for the acute stages, you may complement that with medications. In general, I don't like to talk about medications, but because they may be abused, but I'll just briefly mention here. So these patients, they need definitely some sort of psychotherapy because the problem may be there for some time. So like for the job security, for the anxiety about the disease, about attracting this disease, or for family issues. So they need some sort of psychotherapy and reassurance, and that can be done by a professional psychologist or behavioral sleep medicine therapist. Ideally should be done by them to help the patient. And there are a lot of techniques for cognitive behavioral therapy. Probably is not the time to discuss them there, like stimulus control technique, sleep curtailment. These are some effective techniques that can be used. Also some techniques in the daytime, like for example, avoiding following the news, reading the bad news at night. Just do what you have to do and follow instruction. You don't have to know what's happening everywhere because you will not like fix those problems. Then for the medications, yes, medication can be used depending on the problem that we diagnose. If the patient is diagnosed to have high level of anxiety, then maybe some anxiolytics may help in just relieving the level of anxiety, and then they improve their sleep without using any hypnotic. If the patient has, for example, started to go to some level of depression, again, antidepressants may help. For the hypnotics, I would put them as the last thing because most of these patients, they have some sort of anxiety. So anxiolytics, one of the drugs which is good, but you can use anyone from your drugs, like citalopram is good for the general anxiety disorder, and that causes insomnia, and also have been mentioned in some of the guidelines for the treatment or other equivalent drugs. If you have to use hypnotics for a few days because the patient really is going to severe insomnia that's really affecting them badly, then the Z drugs are good. And in the Gulf now we have zolpidem is available, and we have zobiclone. Zolpidem is a shorter half-life. We have zolpidem SR, but I think it's not available in the Gulf. Both drugs are safe, have been zolpidem approved 1999, so it's known for a long time. We have zobiclone first, then we have zobiclone, which is an extension of the zobiclone. Also, it's a known drug. It's a medium half-life, will be 4 to 6 hours, while zolpidem will be 2 to 4 hours. Both drugs are effective. The choice of the drug probably will depend if the patient has sleep initiation problem, and then once they go to sleep, they sleep well. Probably I'll go with zolpidem. But if they have maintenance problem, then zobiclone may be a better choice. But again, I leave this as the last choices. I will not start them immediately. There are some precautions, again, you have to know about these medications, so you have to make sure patients don't have respiratory problems like COPD or they're hypoventilating. Zolpidem has been known to cause what we call antegrade amnesia, so we have to tell the patient if they start walking after taking the medicine and doing something that they don't recall when they wake up, then they should stop the treatment immediately. Again, these drugs, they have quick action, so I advise my patient to take it while in bed to take the medication, because action is quick. Some of them, they take it and say, okay, I'll go to buy bread, I'll buy this for the kids, I'll go. I have one of my patients, he took the medicine, he went to pray Isha. He said, I don't remember anything. This is what we call antegrade amnesia. He said, people told me that I prayed Isha, I talked to them, I came back home, I don't recall anything. I have a lady who decided to take 4 tablets of Zolpidem. Then she get up at night, she cooked for her kids. Then in the morning, she wasn't recalling any of that. That's very serious. If that happens, you have to stop the medication. And usually it happens if they exceed the recommended dose, which is 10 milligram for Zolpidem. For women, it's recommended to start with 5 milligram by the FDA because of this antegrade amnesia.
Excellent. Well, thank you, Professor. I think it's clear. Managing insomnia, again, there is no magic. One drug, it has to be personalized depending on the patient, as Professor Ahmed just said. And if you have a psychiatrist nearby your clinic, I would recommend that it need to be seen by a psychiatrist who is also, most of the time, would look at the anxiety versus depression. Okay, now we have another very good 2 or 3 questions. I'll go through them quickly. A COVID patient got treated and came negative 3rd week after 21 days. Shall we go ahead with level 1 sleep lab testing or home sleep testing? Professor.
Yes, I mean, if the patient is negative and all the criteria for recovery are there, because the criteria are period for absence of symptoms plus negative second swab. If all are fulfilled, then the study can be done either at home or in lab. If the patient meets the criteria for home sleep apnea testing and it is available, we can do it at home. If not, or if the case is complicated, like probably some giant stroke with hypoventilation, then it's better to do it in lab. So yeah, I mean, if a patient meets the criteria of recovery of COVID-19, yeah, study can be done. But again, as Dr. Muhammad mentioned in his talk, you have to do the screening for them by the questionnaire, by the temperature check, all of this, even if they have been tested to be negative, to make sure that you are not missing any new infection or new symptoms.
Okay, and here Yasser Malik asked a question: can obstructive sleep apnea promote cognitive dysfunction, especially in Alzheimer patient and other neurodegenerative conditions? Professor?
Yes, I mean, there is strong association between cognitive dysfunction and obstructive sleep apnea, which can be reversible or irreversible, probably depending on how long this problem has been there, or probably some genetic components. So we hope that by the time we get the patient, that all cognitive dysfunction will be reversible with treatment, but there are documented cases of irreversible cognitive dysfunction, and also some shrinking of the white matter of the brain on MRI studies in patients with obstructive sleep apnea compared to matched controls. This damage sometimes, if it is late, maybe like you cannot fix it, it's already there. So you hope to get them early and treat them early before they go into the irreversible damage. And there is a link also between obstructive sleep apnea and Alzheimer, has been mentioned. Also a link between Alzheimer and sleep deprivation. So there is a link with that. Yes, definitely. Patients with obstructive sleep apnea will have higher risk of developing Alzheimer. They have the genetic component for that than their peers who do not have OSA.
Okay, excellent. Well, thank you. And I'll take this last question before we move to the last talk. What is the effect of COVID-19 on patients with HHT, I think hereditary hemorrhagic telangiectasia, and have difficulty breathing at night? Professor, would you like to take
Sorry, what was the question again? Sorry, I missed it, Dr. Muhammad.
What is the effect of COVID-19 on patients with hereditary hemorrhagic, I think, maybe tell it, and have difficulty breathing, especially during sleep.
I mean, hereditary hemorrhagic telangiectasia is a different disorder that has its own complications. So patients should be treated like any patient with OSA and COVID-19. If the patient is using his machine at home, if an OSA patient is at home and they put him on isolation, or they put her on isolation because their condition does not need them to go to the hospital, then it's better to sleep in a separate room if they're going to use their CPAP. They should sleep alone, isolation. They shouldn't make sure they don't use the CPAP, even if the test is not there yet, but there is suspicion that they may have COVID-19. Either they stop their device or they make sure that there is no one around them, the room is closed, there is no one around because of the risk of the aerosol. And the hereditary hemorrhagic telangiectasia, they may have exacerbation with all these problems, so that's a different issue.
Yeah. And I think this is the same answer may apply to the last question, who said, I'm an emergency physician and a COVID patient discharged from my hospital called the emergency as he again started having shortness of breath due to chronic obstructive sleep apnea. But he wants to come to hospital. Should he wait for finishing his quarantine and then come to sleep lab, or he need to do rapid antigen test and then come? Please answer. Well, basically, safety of the patients and everyone there, I think the patients better to wait. Now, what we need to know that obstructive sleep apnea did not happen overnight. This patient who is obstructive sleep apnea has been having obstructive sleep apnea for a while. And now if he's suspected to have a COVID-19, for the safety of the staff in the sleep lab and hospital, better that he finish his quarantine. That's my thought. What do you think, Professor Ahmed?
Yeah, I agree with you. I mean, safety of the staff comes number one. OSA is a chronic disease. I mean, if the cause of shortness of breath is a different cause, then he should visit the emergency room to find out the cause of
exactly. Okay, well, thank you. And now for the last 5 minutes, I'd like to present Dr. Saleh Hamid Rifa'i, who's a medical advisor for Zomac. Dr. Saleh is a PharmD graduate from Osmania University, India. He's a board certified in medical affairs specialist from ACMA. He will talk for the last 5 minutes about Zomac, which is Zopiclone. Dr. Saleh.
Thanks a lot, Doctor, for the warm welcome. So my name is Saleh. I'm a medical advisor for Zomac. So we'll be going briefly on Zomac. So it will be a brief introduction to Zomac. So around 15% of the world population is suffering from insomnia. And chronic insomnia leads to several other illnesses, like it increases 30% odds of hypertension, 10 times it increases the risk of clinic depression, and overall, it increases 33% mortality rate. So basically, what is Zomac? A lot of people in the webinar was having this question, like what is the active ingredient of Zomac? So the active ingredient of Zomac is S-Zopiclone. And S-Zopiclone is basically a potent non-benzodiazepine hypnotic. So, and S-Zopiclone is used in the treatment of acute insomnia as well as chronic insomnia. And with Zomac, the patient can not only sleep faster, sleep longer, and stay productive the next day, because the residual symptoms of Zomac are very less compared to others. So Zomac is being approved. It is the first medicine that is approved by MOH for insomnia, and it's approved by FDA for using in chronic insomnia, and it also recommended by American Academy of Sleep Medicine for chronic insomnia. So how does Zomac work? So Zomac acts specifically on the alpha-1 subunit of the GABA receptor, GABA-A receptor. So thereby it causes hyperpolarization of the chloride channels. Thereby it relaxes the neuron and causes relaxation and causes sleep. So the reason for its selective, like it binds selectively to alpha-1 subunit. Thereby it doesn't have the anti-anxiety side effect. And what is the dosage of Zomac? So the started recommending dose of Zomac is 1 mg, and it can be increased to 3 mg if clinically indicated. But if it's a geriatric patient or someone is like have liver damage, the max dose should be 2 mg. And why should psychiatrists recommend Zomac? So Zomac is proven to provide a total sleep time of 7 to 8 hours, and the half-life of Zomac is 6 hours. And as per some of the studies in the sleep onset latency, azepicolone was compared to placebo, and it showed significant difference in increasing the sleep onset time. Decreasing the sleep onset time when compared to placebo. And the good thing about Zomac is the next day residual is minimum with Zomac. It was judged on the basis of Stanford Sleeping Scale. Azepicolone was compared to a placebo, and it was found to have similar effect to placebo. The residual, so that's what the next day residual is very minimum. And in a study, azepicolone was compared to zopiclone in the treatment of insomnia. It was shown that azepicolone had a 2.33% higher sleep efficiency score compared to zopiclone. Also, it has 13.9% quicker onset of sleep when compared to zopiclone. And yeah, a person in the comment was asking about which is the best medicine for insomnia in this one, apnea. So I think there was a meta-analysis done on all the non-benzodiazepine sedative hypnotic, and it was found that azepicolone showed the largest difference in apnea hypopnea index with a mean difference of 5.73 events per hour. And the good thing about Zomac is it is well tolerated and it can be used for long term. So studies showed no evidence of tolerance even after 6 months and 12 months of administration. And there was a study done comparing azepicolone with other non-benzodiazepine hypnotics in the risk of falling after taking the tablets. So azepicolone had the best odds ratio, like the least odds ratio compared to zolpidem and xylophone. And there was no signs of dependence or withdrawal while the patient was using Zomac 1 mg for long term. However, there was like 1% and 2.90% when the patient was using azepicolone 2 mg and 3 mg respectively. And the most common side effect of Zomac is like unpleasant taste, drowsiness, dry mouth, dizziness, rash, and headache. However, the most common side effect, like almost 10% of the patient reports, is the unpleasant taste. And it is the first hypnotic to be approved by US FDA that can be used for long term. All the other hypnotic medicines are approved for using it for short term. And azepicolone was the first medicine to be approved for long-term use of insomnia. And it was the first medicine to be approved by MOH to treat insomnia itself. And that's it about Zomac. Thank you, thanks a lot. If any doubts or any queries, you can just write down in the comment section. Thank you, thanks a lot.
Excellent. Well, thank you, Saleh. Very informative and to the point. A few questions here. Some of the questions are some of the participants are asking questions about any food-drug interaction for Zomac.
Well, see, all the sedative hypnotics have alcohol interaction. Other than that, it is advised not to use Zomac with high fat meals. Using Zomac with high fat meals, it decreases the absorption of Zomac. And that's all reported up till now.
I'd like to thank the speakers, Professor Ahmed Bahammam, Fatima Al-Ahmed, the MCO, UAE University. It was very interesting, and I'd like to thank all the participants. I'm really impressed. More than 500 participants have joined us, and I hope that you learned something today. Please, you'll get an email from the organizer with a survey. Answer the survey and you'll get the CME to your email. Thank you and have a good night and happy new Hijri Eid.
Thank you, Dr. Al-Kani, and thank you, everyone.
Thank you. Bye-bye.
Thank you, Dr.